If I may say so myself, we have been quite successful in our endeavor to try to impart good PG training to our students. We've had stalwarts of a field for the last 5 years taking the time out to come and discourse to our PG students. And one of the people who's always been a rock for our program, not just in terms of logistical support, in terms of providing the good offices of his hospital, but also being an excellent teacher who has been specifically requested for by many PG students on multiple occasions. Dr. Nilesh Shah, he has taught PG students on various platforms. On this platform as well, he has spoken to students in the past on on a wide variety of topics, very interesting topics as well. And keeping in the tradition of his proficiency and his skill set, today he is again going to talk to us about the use of non-psychotropic medications in clinical practice of psychiatry. Topic is obviously not as unique as Dr. Nilesh Shah is. He is one of the stalwarts of the psychiatry world today. His introduction that he wanted me to share with you is very amusing and a very concise one, but it would be grave injustice to him if I do not put on record the fact that he is one of my mentors as well, and I'm proud to, I'm privileged to say that he is one of our senior colleagues and whom I can proudly say that he is a dear friend of mine. He is the professor and head of department of psychiatry at Sion Hospital. He has been a postgraduate teacher for many years and has been invited to be an examiner at various medical colleges across the whole country. He is a speaker at various fora, national as well as international. He has been a crowd favorite of everybody from the JR1 resident to the senior most psychiatrist in our country. And he has an extremely endearing quality about him. And humility is his USP. In accordance of his humility, he asked me to introduce him as the person who was a class monitor in his third standard. He won the third prize in running competition at sixth standard. He acted in a drama in the ninth standard. He's been working at Sion Hospital as a full-timer, as did not get any attachment in any of the hospital as a consultant. He likes watching Hindi movies, traveling, and roadside food. He's married and has twin daughters. So we have a few things in common. Nilesh bhai, I love roadside food. I am married and have twin daughters as well. And he describes his pre-morbid personality as over anxious, but I can tell you he's anything but. He is uh, he is as simple as he is brilliant, and perhaps that is one of the reasons why he's brilliant, because he is not pretentious. He does not care for accolades or care for any kind of fancy titles. He is a pure psychiatrist at heart, pure teacher at heart, and most importantly, a pure human at heart. So uh, I'm really privileged and proud to welcome him back to this forum. This is the first time I've had the pleasure of introducing him, because generally it is one of his subordinates who has the onus of doing that on every occasion. But welcome, Dr. Nilesh Shah. We are really grateful that you could take the time out and come and share your thoughts with us today. And without any further ado, I pass on the onus back to you. Dr. Nilesh Shah, everybody. Over to you, sir.
Yeah, thank you, Rashmin, for that kind introduction. So I'll first load my slides. Okay. So as Dr. Rashmin mentioned, today's topic is little unusual in the sense that I'm going to present on use of non-psychotropic medicines in the clinical practice of psychiatry. So whenever we prescribe medicines, many of our medicines have side effects. And either to prevent the side effects or whenever the patient develops a side effect, we prescribe more medicines. And as I have put it up along with this cartoon. The pharmacist is saying the customer, each capsule contains your medications plus a treatment for each of its side effects. So in our clinical practice, of course, we use psychotropic medications, but we use number of other non-psychotropic medications which may be useful in our day-to-day practice. And I'm going to speak on some of these medications which are little new, which are different, which we may not have used. And if we use it, then probably we will be able to use it more appropriately. So propranolol we have been using, and when the propranolol fails, there are two other medicines. One is ivabradine, which can be used for tachycardia, and another is primidone, which can be used for tremors. So we have now alternatives for propranolol. Propranolol, as you know, for tachycardia we use, and for tremors, essential tremors or drug-induced tremors we use. And if it is effective, we continue to use it. But sometimes propranolol, if you find is not effective, then you have other medicines which you can add to propranolol. One is ivabradine and primidone. So we are going to talk about ivabradine and primidone. Excessive salivation is one of the problem. So we have this glycopyrrolate and atropine eye drops, which we can use apart from clonidine, amitriptyline, mirtazapine, which we have been using for excessive salivation. And similarly for dryness of mouth, there are medicines which we can use like pilocarpine. So we will talk about atropine, pilocarpine. Another common side effect is giddiness, and giddiness may be because of less water. Fludrocortisone, and we have also tolvaptan. Then galactoria amenorrhea is another side effect for which we use bromocriptine, cabergoline, and of course our own psychotropic medication aripiprazole. Many of our medications cause restless leg syndrome, so for that we use pramipexole or ropinirole. Of course, we also use ketamine, metformin, ondansetron, and urinary incontinence. We use oxybutynin, tolteridone, derifensin. And recently, in one of the patients, I had the opportunity to use desmopressin for post-head injury, diabetes insipidus, and varenicline for excessive sugar craving. So I think one by one, I will talk about these medicines. So let me start with the first case which we had. Ivabradine for clozapine-induced tachycardia. We had this 35 years old male, a case of chronic treatment refractory schizophrenia. Showed significant improvement with clozapine and ECT. Now, we were giving ECT, but ECT had to be withheld as his pulse rate on clozapine, 400 milligrams per day, increased to 130 to 140 beats per minute, in spite of being on 80 milligrams of propranolol for akathisia. So already he was on 80 milligrams of propranolol, and in spite of that, on 400 milligram of clozapine, he had tachycardia. Now we know almost 25% of the patients on clozapine develop tachycardia as a side effect, and their pulse rate increases to 110, 130, 20, and in rare cases 130 to 40. Now, along with clozapine, with which he showed improvement, we had to continue ECTs also. Now, obviously, we did all the investigations, his complete blood count, thyroid function test, ECG. We also took the medical opinion for tachycardia, cardiology opinion, and all other things were normal. And so our conclusion that this is clozapine-induced tachycardia. So now already he was on 80 milligrams of propranolol and still he had tachycardia. So after a medical reference, he was started on a new medicine called tablet ivabradine. We started with 5 milligram twice a day. His pulse rate gradually decreased to around 100 beats per minute, and we could resume ECT. Many of you know that when we give ECTs, the pulse rate acutely increases, and then again, once the convulsions stop, the pulse rate comes down. Now, if the pulse rate is around, say, 70, 80, 100, it will increase to 130, 140, and again it will come down. But if the pulse rate is already 140 per minute, and you give ECT and it causes more than 180, then there are possibility of cardiac complications. And that's why anesthetists warn us that the basal pulse rate should not be very, very high, preferably not more than 100. So in this case, we use ivabradine with good results. And then we reviewed the literature and we found that already there has been a case report of ivabradine, a novel treatment for clozapine-induced sinus tachycardia, and it was a case series. So there were 2 cases which were published in this journal. They have mentioned we present 2 cases of patients with treatment-resistant schizophrenia who developed symptomatic tachycardia associated with clozapine. We demonstrate that the novel heart rate controlling agent ivabradine can be effectively and safely used to control the heart rate and to allow for the continued treatment with clozapine. And according to them, this is the first report in the literature demonstrating that ivabradine appears to be well-tolerated agent which should be considered as a symptomatic treatment for clozapine-induced tachycardia if use of a beta blocker fails due to lack of response or intolerability. So this is a new agent used mainly by medical people, cardiology people, particularly for sinus tachycardia, and it's an HCN receptor blocking agent, and it works on SA node, and when it works on SA node, it inhibits the SA node, and that's how it controls the tachycardia. So one agent which we have to learn to use now is ivabradine, which can be used for drug-induced tachycardia, particularly clozapine-induced tachycardia. Another agent which nowadays we can use is primidone for severe tremors. As I mentioned about ivabradine, that propranolol is a first-line treatment, and when propranolol fails, you use ivabradine. Similarly, for drug-induced tremors, or even for that matter, essential tremors, propranolol is a first-line treatment. Now, when propranolol fails, or it is not sufficient enough, or it is contraindicated, say for example, person has bronchial asthma. So in that case, we avoid propranolol because propranolol can cause bronchoconstriction. So that's why it is avoided. So here we have a case, 69-year-old female, a case of bipolar mood disorder in mania, showed very good response to tablet olanzapine 20 milligrams per day and divalproic sodium 750 milligrams, but developed severe tremulousness which did not respond to 80 milligrams of propranolol. Her symptoms would reappear on dose reduction. So we had to continue her on 20 milligram and divalproic sodium 750. And we had to add something so that she will not develop tremulousness. So because she did not respond to 80 milligrams of propranolol, we added tablet primidone 250 milligram once a day. At that time, primidone was available as misolin. And as you know, primidone is a very, very old drug. It's a kind of phenobarbital, which we have been using. And after the Gardinal, primidone was introduced in the market. In fact, it's one of the metabolite of phenobarbital, and it was introduced as an anti-epileptic drug, but it did not pick up very well. We had other anti-epileptic drugs like Eptoin, carbamazepine, and sodium valproate, and now levetiracetam. So primidone was not used, and at that time it was available as Mysolin 250 milligram tablet. So we started her on 250 milligram of primidone, and it brought about almost complete remission in her tremulousness. Now primidone is also available as 50 milligram, 100 milligram tablets. So if you don't want to start directly with 250 milligrams, you can start with 50 milligrams, 100 milligrams, and then gradually increase the dose as required. So as I mentioned, primidone, an anti-seizure drug, is also effective for treating essential tremors. It is most useful for people with hand tremors, but sometimes even for the neck tremors or head tremors, it is useful. Primidone appears to be as effective as propranolol, with significant suppression of tremors in most patients. Some people may develop tolerance to the treatment after about a year, but in most cases, primidone is given to people who do not tolerate propranolol or who do not respond adequately to propranolol. Primidone can also be given in addition to propranolol to improve the symptoms. So propranolol is our standard drug, first line drug. Most of us have used it. But when propranolol fails, either in bradycardia, you use ivabradine, and when propranolol fails or does not give sufficient response in essential tremors or drug-induced tremors, you can add or use primidone in its place. Another common problem is clozapine-induced cyalloria. And as I have mentioned in this cartoon, some people believe that people who drool while sleeping can count themselves lucky. So just tell your patient that, oh, you are very, very lucky that you have drooling of saliva. Only lucky people get drooling of saliva. And if they are okay with it, if their salivation is not very, very big amount and it remains on the pillow for a while and it's not much of a problem to the patient or his relatives, let it be. But many times they are very, very upset because of this continuous drooling of saliva, particularly at night. They keep their napkins, etc. But still, now in that case, if you need to treat, then we have to do something about this continuous excessive salivation. Now, basically, unfortunately, we do not really know why clozapine causes so much of sialloria. They have considered muscarinic mechanisms, adrenergic mechanisms, histaminergic mechanisms, and also difficulty in swallowing. So clozapine can induce difficulty in swallowing, and because of that also the saliva gets accumulated in the mouth. So we have tried various other things like atropine, amitriptyline we have been using. We have been using mirtazapine and glycopyrrolate, trihexyphenidyl we have tried. So clonidine we have tried. So these are glycopyrrolate, trihexyphenidyl, that is pacitane, clonidine, amitriptyline, mirtazapine. All these things have been tried. Some of these are useful. Some of these medicines may not be useful in a given patients. In that case, nowadays what we are trying is atropine 1% eye drops. We recommend 2 to 5 drops in the mouth orally. The patient has to take 5 drops in the mouth, swish and spit. So like this with the tongue movement all over. After taking 5 drops in the mouth, he has to spread atropine in the mouth all around, and then whatever is little remaining in the mouth, he can spit it. And depending on the amount of sialloria, he can do it 2 or 3 times in a day. And we have seen in clinical practice that it gives very good results. they develop dryness of mouth, and the systemic effect of anticholinergic drugs, like suppose you are giving pacitane or glycopyrrolate or amitriptyline for that matter, they also develop constipation and sedation, and mirtazapine causes sedation. So these side effects are avoided because atropine, when you are taking orally in the mouth, it has only local effect. The only thing you have to tell the patients that after putting the drops in the mouth, you spread it and spit it out. But after spitting it out, don't rinse your mouth. Otherwise, some patients, if they rinse their mouth, the atropine which has been given will be removed from the mouth and the effect will wear off. So do not rinse your mouth after putting the drops and after spitting it out. So excessive salivation, nowadays we use atropine eye drops, and you have to tell specifically to the patient that though it is eye drops, you don't have to put it in the eyes, but you have to put it in the mouth. As clozapine-induced sialorrhea is a big problem, similarly, dryness of mouth is a big problem for many of our patients. Almost all antidepressant, amitriptyline, imipramine, nortriptyline, mirtazapine, many of these drugs and many antipsychotics which have high anticholinergic side effects cause dryness of mouth. Now for dry mouth, the recommended drops is pilocarpine. Again, it's an eye drop, 4% eye drops, and you put it in the mouth. Again, swish, that is spread it in the mouth and spit it out. And that also 4% pilocarpine eye drops can be used 2 to 3 times in a day. Day before yesterday, I had a patient and she had severe dryness of mouth. And I had told her to keep something in the mouth, say manuka or a piece of grape, dried grape in the mouth. And if you keep it, as long as it is there, the salivation will continue and you will not feel dry mouth. So we tell the patient that take plenty of oral fluids, keep something in the mouth like manuka or grape, dried grape over here, and saliva will continue. But some people find it useful, some people do not find it useful. So this patient went to dentist because she was feeling very dry mouth, and she was given this saliva substitute, which is carboxymethyl cellulose solution 0.5%. This solution is available as one of the brand name is Wet Mouth. So they have to just take a half a spoon of this 0.5% carboxymethyl cellulose, put it in a little water and just rinse their mouth the way we do it. And dryness of mouth is taken care of. They can do it once or twice again. And my patient found it very, very useful. And she said after using this wet mouth, the carboxyl methyl cellulose solution, that problem, because she said she could not sleep throughout the night because of dry mouth, because that dry mouth, she had to repeatedly get up in the middle of the night, drink water, again there will be dry mouth. And after using this saliva substitute, she is now much better and she doesn't have to repeatedly get up in the night and rinse or drink water for dry mouth. So I found it very interesting and I thought I must share with you that we can use either pilocarpine drops or saliva substitute, carboxyl methyl cellulose, something like wet mouth solution for dry mouth. Another medicine which we can use, which is again not a psychotropic medication, is tolvaptan. And tolvaptan is useful for hyponatremia. Here we had a case of 53-year-old female, case of major depression on escitalopram 20 milligram at bedtime. She presented with weakness and low sodium level of 126 milliequivalent per liter. Clinically, there was no evidence of dehydration, because one of the causes of this weakness may be dehydration, but clinically we examined and there was no dehydration. And she was suspected to have SSRI-induced SIADH. Now we know that many of our SSRI, escitalopram, paroxetine, and almost practically all psychotropic medications can cause SIADH, that is syndrome of inappropriate antidiuretic hormone hypersecretion. So because of this, escitalopram or any other psychotropic medication, there is an excessive secretion of antidiuretic hormone. And antidiuretic hormone acts on vasopressin receptors 1 and 2, and that causes excessive retention of water. And this excessive retention of water causes dilutional hyponatremia. So it is not low salt, but it is excessive water which is causing dilutional hyponatremia. So she was asked to withhold tablet escitalopram, and she was asked to take only 800 ml of water, which is the treatment for SIADH, fluid restriction, because as I said, it's actually a fluid overload causing hyponatremia. So the main treatment is restricting the water intake to 800 ml per day, and take half teaspoonful of extra salt, that is 3 grams of extra salt in capsule. So put it in the capsule and take it. Along with these measures, one can also nowadays, because this new drug is available, tablet tolvaptan is available as 15 milligram and 30 milligram tablets. You have to give it only 1 tablet per day. You can give it for it's a packet of 4 tablets. So give it for 4 days, and if necessary, you can repeat it for 4 more days. So 8 days, and within 8 days, usually the blood level of sodium comes back to normal. Hyponatremia is taken care of. Fluid overload is taken care of, as the patient will drink less water, and that weakness associated with SIADH improves. So one more medicine which we can use is tolvaptan, which is a vasopressin receptor antagonist. So it prevents the effect of antidiuretic hormone on vasopressin receptors, and particularly very useful in drug-induced hyponatremia. Similarly, many of our patients complain of severe giddiness. So this 59-year-old male, a case of schizophrenia and OCD, obsessive compulsive disorder, he was on clozapine 50 milligram and clomipramine 75 milligram along with other medicines. He was not on any antihypertensive drugs. Complained of postural hypotension and fear that he may fall. Now, both these medicines, clozapine and clomipramine can cause severe giddiness, and suddenly when the patient changes the position, tries to get up, there is a darkness in front of the eyes and the person might fall. So usually variety of measures we recommend. We say that they must take 2 to 3 liters of water daily. High salt intake they should take. They should keep their head little head up tilt at night by raising the bed head by blocks or firm pillow beneath the mattress. Change position slowly and carefully. And nowadays we have tried this Floricort, that is fludrocortisone. It's an aldosterone. So it increases the absorption of sodium from the in the kidney. So Floricort 100 micrograms, 1 tablet given throughout the day or at bedtime. 100 microgram is the dose, and it's little expensive. 140 rupees for 10 tablets. Tolvaptan is also expensive. 400 rupees for 4 tablets. So if you take these measures along with Floricort is another new medicine which we can use, fludrocortisone, for giddiness, along with other measures like increasing intake of water. People have tried tablet ephedrine 15 milligram 3 or 4 times a day, midodrine, desmopressin at bedtime, but all these are not easily available and not and very expensive. So instead of that, nowadays we use Floricort tablet in the patients who complain of postural hypotension. Many of our patients on typical antipsychotic drugs and many patients on risperidone, amisulpride particularly, develop amenorrhea, galactorrhea. Now, for these patients, we have bromocriptine and cabergoline, and of course, our own aripiprazole. We have been using bromocriptine for treatment of neuroleptic malignant syndrome and conditions associated with psychotropic medications induced hyperprolactinemia like galactorrhea and amenorrhea. So we all have used bromocriptine mostly for NMS, but we can also use it for galactorrhea, amenorrhea. The first line treatment in patients with schizophrenia who develops particularly amenorrhea is aripiprazole. We use aripiprazole 2.5 milligram, 5 milligram, 10 milligrams, and within 3 to 4 weeks or at the most 6 weeks, the patient starts getting the regular periods. So amenorrhea is not very difficult to treat. We know that it is because of antipsychotic induced hyperprolactinemia, excessive prolactin. In fact, you can check the blood level of prolactin and find out whether the person has hyperprolactinemia or not, and whether amenorrhea is because of hyperprolactinemia or not. So along with the antipsychotic, you add aripiprazole and the person starts getting regular period. But if you don't want to use aripiprazole or aripiprazole doesn't work, particularly for galactorrhea, then we have this another option of using bromocriptine, which is available as B-crypt or proctinal tablet 2.5 milligrams 3 times a day. And in NMS, the maximum dose which we have used is 30 milligram per day. So 444 tablets, 12 tablets of 2.5 milligram, that is 30 milligrams per day. Similarly, cabergoline may be used for drug-induced galactorrhea and as an adjuvant to SSRI antidepressant to counteract reduced libido and anorgasmia. Cabergoline is a very potent medicine, and usually it is not prescribed every day. One has to remember cabergoline, very, very small dose of 0.25 milligram, only once or twice a week is used. So if the patient has galactorrhea or patient has SSRI induced reduced libido and orgasmia, then you can use cabergoline 0.25 milligram twice a day. And of course, aripiprazole may be used for drug-induced amenorrhea, 2.5 milligram to 15 milligrams. Wait for 4 to 6 weeks and patient will start getting regular periods. The report suggests almost 80% success rate with aripiprazole, particularly for drug-induced amenorrhea. But apart from amenorrhea, if the patient has galactorrhea and reduced libido and anorgasmia, one can consider bromocriptine or cabergoline. Another drug which we have been using routinely, very frequently, which is to extent not a primary psychotropic medication, is pramipexole. Pramipexole is a dopamine receptor agonist, and one of the treatment which is used in patients with Parkinsonism along with syndopa, which is the main treatment for Parkinsonism. So pramipexole, a very useful drug for bipolar depression and restless leg syndrome. We start with 0.25 milligram, and in bipolar depression, you increase it up to 3 milligram per day. It is available as Pramipex, Pramirol, Mirator. These are the few brand names. And as most of us know that restless leg syndrome is a common disorder, either alone by itself or drug-induced in many cases. And when the patients go to sleep, they complain of pulling sensations in lower leg, restlessness. They have to stretch their leg, kick, get up and walk, and then only they are able to fall asleep. So this is a big problem. And for that restless leg syndrome, either by itself or drug-induced restless leg syndrome, clonazepam may be used. But when clonazepam doesn't work, then you can use pramipexole. And similar drug, again dopamine agonist, ropinirole, is also promoted for restless leg syndrome. Ropinirole is little cheaper than pramipexole, again 0.5 milligram per day. Ropinirole is available as Ropark tablet. So two new other medicines, pramipexole and ropinirole, which you can use for bipolar depression, resistant depression, restless leg syndrome. Ketamine, as we know, is an anesthetic agent. And ketamine can be used for treatment-resistant depression, treatment-resistant obsessive compulsive disorder. We have been using ketamine now for almost 5 years on regular basis, and many patients are referred to us in Sion Hospital. Ketamine 0.5 milligram per kg body weight is given intravenously in 100 ml of saline over a period of 40 minutes. You can give it every day, 5 or 6 days a week, or you can give it on alternate days. And many patients show good response to ketamine treatment for treatment-resistant depression and treatment-resistant OCD. So anesthetic agent which can be used for treatment-resistant depression. Metformin we have been using for olanzapine-induced weight gain. And in fact, one of our student did his postgraduate thesis, MD thesis on this topic. The patients who required olanzapine were put on olanzapine and followed up over a period of 3 months. And other patients, other group of patients who were given olanzapine, they were told and given along with olanzapine metformin also. And what we found that those who received only olanzapine gained about 7 kg of weight over a period of 3 months, while patients who was also along with olanzapine taking metformin gained only around 3 kg. So almost 50% reduction in weight gain due to metformin. So one has an option of combining metformin along with olanzapine in order to reduce the weight gain because of olanzapine and subsequent of obviously what we call metabolic syndrome, which occurs because of excessive weight gain due to olanzapine. Ondansetron, 5-HT3 antagonist, has been used for acidity or vomiting. We have been using this ondansetron, but nowadays ondansetron has also been tried in treatment-resistant schizophrenia, particularly when the person has negative symptoms of schizophrenia, and it has also been tried as an anti-craving agent for alcohol use disorder. So if the patient with alcohol use disorder also has nausea, vomiting, you can add ondansetron. So it will have a double benefit. Vomiting will also stop, and also it may also take care of the craving. And similarly, many patients with schizophrenia who have repeated vomiting or acidity, so along with pantoprazole, you can combine ondansetron. So either way you can use it in combination with antipsychotic drugs, ondansetron, for treatment-resistant schizophrenia, particularly when patient has negative symptoms. Another problem many of our patients have is incontinence. I think very well known is a clozapine-induced incontinence, bedwetting, because clozapine is a very, very sedative drug, and people go to sleep at bedtime, and then they go into very, very deep sleep, and then bladder gets full. They otherwise they get up and go, but sometimes it's very difficult because of the deep sleep, they are not able to get up. So there is a bedwetting. So we have used variety of medicines like our regular medicine, imipramine, we use. So imipramine, people have tried desmopressin, amitriptyline, aripiprazole, and we also recommend that when you use imipramine for clozapine-induced bedwetting, also you can wake up the patient after 1.5 hours, because most of the patient pass urine after 1.5 hours. So you can wake up the patient, patient will get up, go and void urine and again can come back to sleep. So one of the option for clozapine-induced bedwetting or incontinence, many patients with dementia have incontinence. So you can use imipramine. Imipramine is a psychotropic drugs, but another medicine is oxyspaz, oxybutinin. So oxybutinin is very useful in bedwetting. You can use 2.5 milligram or 5 milligram once or twice a day. So that will take care of incontinence. And a drug similar to oxyspaz, that is oxybutinin, tolterodine, and derifensin. Tolterodine and derifensin are a little more expensive because they are newer drugs. But for all practical purposes, our patients, you can use oxyspaz, that is oxybutinin, for either clozapine-induced incontinence or incontinence in patients with dementia, with behavior problems. And finally, recently, about a month back, I had this case of post-head injury diabetes insipidus. So the patient was actually referred to me because patient was very, very restless, not able to sleep, repeatedly getting up, asking for lots of water. So he was continuously drinking water throughout the day. And then because of excessive water consumption, he was repeatedly going to pass urine. And so because he had to repeatedly go to pass urine, the other members were disturbed. They were also not able to sleep, and he was 86 years old. And actually, all these things had started after head injury. He had a fall, and after that, he had a head injury, subdural hematoma, and it had to be evacuated twice. And after head injury, he had developed. So this is a condition which is called as a post-head injury diabetes insipidus. And along with this, he also complained of severe sugar craving. So sometimes after head injury, patients want lots of sugar. So sugary drink they ask for, or mithai, good sugar, sweets they ask for, and they keep on eating because of sugar craving. So for post-head injury diabetes insipidus, we recommended desmopressin nasal spray. The strength is 10 microgram, 0.01 ml, and you can give 10 to 40 micrograms. So let him spray once in one nostril, another nostril once a day. That will be 20 micrograms, and he can do it twice or even sometimes thrice. And that will take care. And after doing that, his frequency of micturition decreased, and excessive water consumption also decreased. Similarly, if varenicline we have been using for smoking cessation. Chempix is the brand name for varenicline which is available, and we use it for smoking cessation. But additionally, it also has anti-craving effect for sweet food. So after any medicine or after a head injury kind of thing, if the patient has excessive craving for sweet food, you can consider giving him varenicline, that is Chempix, and that will reduce his sugar craving. So a few new medicines you can learn, desmopressin and varenicline. And if we have more medicines in our armamentarium, we can treat the patients, our own regular patients, treatment-resistant patient, and we can take good care of their side effects which they develop because of these medicines. So thank you very much, friends, for this patient listening, and thank you very much to Dr. Cholera, Rashmin Cholera, for nice, kind introduction and giving me this opportunity to make a presentation on this topic. Thank you very much.
Thank you so much, Dr. Nilesh Shah. As expected, and as we have come to know from all your past lectures, it was brilliant. Brilliant in its simplicity, yet in its relevance to everyday psychiatry practice. And it was quite an eye-opener in many respects, because we use these drugs very routinely, but we may not necessarily know how they work or their implications. So thank you again, and the forum is now open for questions. I would request all of you to please post your questions in the chat box, or if you wish to, you can unmute yourself and you can ask the question as well. But the chat box is a more logical option.
Good evening, sir.
Yes, go ahead.
Sir, I have seen there was sir also mentioned regarding metformin for the patient who are taking olanzapine. So, sir, the thing is, should we wait? Like, because of course, due to the side effect of olanzapine that leads to diabetes, is it can we start it like before the sugar level gets up to pre-diabetic level? Can we start when the patient doesn't have any indication for the diabetes? Still, can we use metformin?
Yes, very, very important question, Tarun. Thank you very much for asking this question. It's a very good question.
Hello.
Usually what we do nowadays, that many patients who require olanzapine, we start the patient on olanzapine, and on the first follow-up visit, which is usually after 1 week, we ask them about the appetite, because we don't wait till they get 7-8 kg weight. So on the very first visit, the simple question is, bhook zyada lagti hai kya? And if the patient says that bhook zyada lagti hai, that is excessive appetite, then that is an indication that this person is going to eat a lot, and as a result he will put on weight. And then if they put on weight, he is at a risk of type 2 diabetes over a period of time, particularly middle-aged person. So in this kind of situation, one option is to reduce and change the medicine. And if that is not possible and you want to continue, then you can give him the option of metformin, that along with olanzapine, just for reduction of excessive appetite, and he doesn't have diabetes, but only for suppression of appetite, you can give metformin. Just to share that metformin is a very, very safe drug in most of the patients. And metformin is also used for prevention of dementia and cognitive decline. And it is also considered as a longevity drug. So there are few trials, longitudinal trials, where they are trying that if the patient is taking metformin, would it improve his lifespan? So metformin, and luckily it's a reasonably well tolerated medication, and there is no risk of hypoglycemia with metformin. So it can be safely administered.
Great. Thank you, Dr. Nilesh Shah. I think it was a very relevant point, and like he rightly said, a lot of people are using metformin as a prophylactic drug rather than a treatment drug. So it has, and it's a safe drug, like Dr. Nilesh Shah said. You would hardly ever get hypoglycemia induced by metformin. It will correct hyperglycemia, but it will never ever lead to hypoglycemia. Dr. Rakesh Belgudri has a question. Good evening, sir. In geriatric patients, how much is the risk of developing anticholinergic delirium with the use of imipramine for incontinence of urine? Nilesh bhai.
Yeah. So the question is, in elderly patient, what is the risk of developing delirium because of imipramine?
Yes.
Okay. We have been using imipramine in young patient as well as elderly patients for bedwetting. And I have hardly seen delirium because of imipramine in elderly patient, for the simple reason that we do very, very small dose. We use imipramine 25 milligram only once at bedtime. And along with that, we ask the relatives to wake him up after about 1.5 hours of going to bed. So this is a kind of conditioning which is occurring. We are not using imipramine as an anticholinergic agent, but as a agent which will reduce the depth of REM sleep or NREM sleep. So usually the bedwetting occurs because of very deep sleep. So in order to lighten the depth of the sleep, we use imipramine. So imipramine lightens the sleep, and it is easier for the patient to wake up when his bladder is full, or it is easier for the relatives to wake him up when the bladder is full. So imipramine in 25 milligram, hardly very low risk of causing delirium in elderly patients.
Very true. Dr. Mohit Shulapurkar has a question. Any experience with Dexmed 50/100 for delirium tremens? And when patients don't get sedation with lorazepam and diazepam, then what do we do?
Okay. Thank you, Mohit, for asking this question. Unfortunately, I have never used this drug called Dexmed. And none of the companies, see, usually we come to know about a new medicine or a different medicine through companies or through our medical colleagues who have been using this, or anesthetists who have been using it. Now, I have not come across this medicine Dexmed 50 or 100 for use in delirium tremens, but recently there was some discussion on our EIPS group, but I have not used. Nowadays, what we use, if the patient doesn't get sedation with lorazepam or diazepam, we use quetiapine. And see, lorazepam and diazepam are like applying the brakes. So it enhances the GABAergic mechanism. So you are potentiating GABA. So that is like applying the brakes. Now, when you apply the brakes, you have to release the accelerator, and the accelerator is histamine. So when you enhance GABA, you have to block histamine, and histamine you can block by either antihistaminergic drugs, which the skin people use, or drugs which are tranquilizers like quetiapine and clozapine. Many times when lorazepam or diazepam doesn't work, we use quetiapine or clozapine for sedation.
Right. Thank you. Tarun has a question. The ideal atypical antipsychotic to switch from olanzapine. Now, this is outside the scope of this particular discussion, but nonetheless, we'll allow one transgression. But I would request the audience to stick to the to a relevant question in terms of the topic today. Dr. Nilesh, would you like to answer it?
Yeah. So we use number of other antipsychotic drugs if the patient is putting on weight with olanzapine. At Sion Hospital, haloperidol is available free of charge, so we can use haloperidol. Blonenserin is available in our Sunday Friends group, so we use blonenserin. You have option of risperidone, and if the patient is not responding to olanzapine, you can use clozapine. So haloperidol, blonenserin, risperidone, clozapine are the alternative antipsychotic medications which you can use if you want to switch the patient from olanzapine for whatever reason.
Right. Dr. Bharti Challa has, I think, more a comment than a question. There are many people in the 50s and 60s who become delirious even with lorazepam when given with antipsychotics for sedation. She has no specific question. So would you like to just address that point?
Yeah. I appreciate your observation. And if you have seen, you are right that sundowning has been reported, confusion has been reported with lorazepam, and we all know that more the number of medicines, more chances of side effects. So antipsychotics already have sedative effect, anticholinergic effect, and to that, if we add lorazepam, there are chances that elderly people, particularly above 60, will develop side effects like delirium. So one has to be careful, as you have mentioned, and obviously the principle in elderly patient, start low, go slow, and use minimum number of medicines at minimum doses, at minimum frequency. because one of the risk in elderly people is delirium. So I fully agree with you that we have to be very, very careful in using multiple drugs, high dose antipsychotics and benzodiazepines when we do it in elderly people.
Right. Any other questions? But I think most people have had their questions addressed. If I may, Dr. Nilesh Shah, I have a question. I remember you having talked about the use of tolvaptan at an earlier discourse. You had talked specifically in with the brand name Natrise, which was commonly used earlier. Of course, now you have many more brands. But in your extensive practice, what are the common side effects that you have seen with tolvaptan?
Okay, so I have used it in obviously very few patients, maybe less than 10 patients. And I have not seen any side effect for the simple reason that we use it only for 4 days. So we
Right.
start the medicine after 4 days. When we repeat the serum sodium level, and if it is normal, then we stop use of tolvaptan. So it is reasonably safe, and I have not observed, but one has to be careful. And electrolyte disturbances, because now you are kind of blocking the vasopressin receptors. So electrolyte disturbances can occur in these patients. So one has to be a little careful. Don't use it for a very long time. Remain in touch with your medical colleague in consultation. Use it. So I think one has to be a little careful because primarily it's not our drug. There was one patient in whom we used tolvaptan, and after a while when we did his serum sodium level, it was 175. So the medical colleague said that it is probably because of tolvaptan, but probably that report was wrong, and the very next report was normal. But yes, hypernatremia can happen rarely with tolvaptan.
In a few patients where we have used it, particularly indoor patients who had comorbid medical conditions too,
Huh.
the physician had advised tolvaptan natrise initially 15 and then up to 30 milligrams. But then the patient had a lot of complaints of nocturia. They had
Okay.
a challenge in terms of having to get up frequently in the night because they needed to pass extra urine. So, have you noticed something like that as well?
Uh, since you have observed, it must be there, but I have not noticed that. We have used it mainly in OPD basis, and
Okay.
nocturia probably I have not observed, but that may be one of the side effect of tolvaptan, because of now you are preventing the reuptake of water, and so
Correct.
more urine will be formed, and patient will have to go repeatedly to pass urine.
Right. Uh, Dr. Bharti has another question. This time, weight gain with olanzapine remains the same with risperidone too, and aripiprazole is not that effective either. What drug do you suggest in such cases? I think you partly answered it, but nonetheless.
Yeah, clozapine. Nowadays we use clozapine. Clozapine is very, very effective in most of the patients who are treatment resistant. We at Sion Hospital, we are pro ECT, so we use ECT. There are papers on clozapine fortification with amisulpride. So combination of clozapine with amisulpride has been tried, and number of other non-pharmacological measures, particularly uh, vocational training or sheltered workshop, trying to social skill training, etc. for the patient. And for negative symptoms, people have tried, we also try modafinil in the morning to make him more less lethargic. So many other options are available.
Right. Dr. Imran has a question. Again, parallel question to our discussion. Can tolvaptan be used for correcting hyponatremia in cases other than SIADH?
Uh, there are three similar conditions. See, primarily, uh, Tolvaptan is a vasopressin receptor antagonist. So whenever there is excessive uh, antidiuretic hormone secretion, you want to block those receptors, vasopressin receptors, and for that it is used. I am not aware of any other use, but definitely if there are other use, you can share with us and it will be useful.
Great. Uh, are they, yes, then uh, they have a question from somebody who goes by the code name of 123456. What should be the dose of ondansetron as anti-craving drugs, and for how many days we can continue with it?
Okay. The ondansetron is available as 4 milligram tablets, and usually as an anti-emetic dose, we use 4 milligram twice a day, sometimes 3 times a day.
Right.
I'm not very sure of anti-craving dose because I have not used it particularly myself, and uh, but I really don't know about the anti-craving dose. If somebody knows it, they can share.
Uh, sure. Thank you. Dr. Imran has another question. Does the weight gain induced by neuroleptic reverse after discontinuation of the medication?
Okay. Not necessarily. It is very, very difficult to lose weight which is gained with neuroleptics. So unless you take very special measures like food restrictions, and you will have to make very, very active efforts to lose weight. But otherwise, even after stopping neuroleptics, many patients do not lose weight. So one has to be careful that in the first place, you be very, very careful that the patient doesn't get very much weight, because it's very difficult to lose that weight once you have gained.
Right. Great. Uh, Thank you so much for all your questions. And I think we're also running out of time. So I take this opportunity to once again thank Dr. Nilesh Shah on the behalf of all the postgraduate students. And now, of course, we have many senior consultants also joining into these lectures because clearly they serve a purpose and they provide some value. And in his usual simplistic manner, Dr. Nilesh Shah has very lucidly pointed out to a whole bunch of other medications which we can use and we probably do use in a day-to-day practice. But he has given us a bird's eye view of the scientific perspective of the correct way to use these drugs and perhaps teach us a few more tricks to manage our patients a little better. So once again, Dr. Nilesh Shah, I thank you on behalf of all the postgraduate students, all the consultants, and of course, D.Y. Patil Hospital and Department of Psychiatry at D.Y. Patil Medical School. It would be remiss on my part to not mention the fact that we have an absolutely clear mandate from Sun Pharma, absolutely no strings attached, educational grant and support from Sun Pharma. So we are very grateful to them for having continued to supported this venture. And it's a matter of pride for us that we have many senior faculty like Dr. Nilesh Shah who often come along on this forum and help our postgraduate students learn a lot more about the basics as well as the advanced side of psychiatry. So thank you all once again, and please join me in thanking Dr. Nilesh Shah once again. Thank you, Doctor, and I wish you all a very good evening. Thank you.
Thank you very much, everyone.